Next, I'd like to move on to introduce Dr. Elliot Brea. He is a thoracic medical oncologist and another colleague of mine at Dana-Farber Cancer Institute. He is an instructor of medicine, also at Harvard Medical School, working on cellular therapies and solid tumors. We'll review CAR-T developments for non-small cell lung cancer and related modalities. Dr. Brea?
Great. So thank you, Dr. Marks. I'm, really excited to talk about some of the exciting developments in cellular therapy. I think, as a patient, you may hear a lot about some of the development of things like CAR-Ts, and I think it's an exciting time, and we're hoping that we can really extend these to our lung cancer patients. By way of background, CAR-Ts are a little bit different than some of the therapies, though there were some similarities similar to what Dr. Cooper had mentioned, talking about T-cell engagers, specifically what CAR-T cellular therapy, and we'll talk about also other platforms of immune effector therapies, work with using a patient's actual immune cells. And the way this works is that patients have blood drawn where specific cells, in the case of CAR-Ts, the T cells, these are potent cells that we know actually play a big role in fighting cancer and immunotherapy, like Dr. Ricciuti just mentioned with some of the development with immunotherapy. But specifically now, instead of giving drugs like antibodies to stimulate the T cells, they're actually engineered using a virus. And so you can see that this virus is able to basically reprogram the T cells and turn them into very potent fighting machines against the cancer. They express these molecules on them, which are actually usually fragments of what an antibody looks like. But these then are supercharged to target against a specific antigen or something on the surface of a cancer cell. These CARs can then be expanded and reinfused back into a patient. Typically, to prepare the patient's body, they often get some chemotherapy to basically prepare the body to receive the CAR-Ts. And then, the hope is that the cancer cells will be found by the CARs and they recognize and kill them. And this can be a quite potent process. These are FDA approved for diseases like multiple myeloma, lymphoma, and leukemia. These are all blood cancers. And we're hoping to extend this into solid tumors like non-small cell lung cancer and small cell lung cancer. So why don't we talk about a few of the exciting developments. I'll start by talking about lifileucel. This isn't technically a CAR therapy, though, it's similar to in that kind of realm of taking a patient's cells and really trying to supercharge them to fight cancer. And this was an interesting trial because what it did is it harvested what had been known to be a very important player in terms of how the T cell or these immune cells respond against cancer by taking biopsies of patients, isolating these T cells and growing them, outside of the body and then reinfusing them back into the patient. So very similar to CAR-T, the technical differences are not engineered with the virus. But what, they have shown is that this has shown responses in non-small cell lung cancer. On average, we saw about a 20% response rate in this trial. And interestingly, these patients were all treated with immunotherapy. And, I think that's really what we struggle with as oncologists is, after somebody's progressed on immunotherapy, are there approaches to, potentially still utilize the immune system to really fight the cancer? And so I think that was where a lot of the excitement with this treatment really came about. And this is, showing different responses in various patients as well, with some patient having, a fairly durable, complete response to the treatment. I think one of the other interesting things that was seen from this trial is, again, these patients were, fairly heavily pretreated. They, harbored these mutations in genes like KRAS, but specifically mutations in other genes that often confer what we call resistance or lack of response to immunotherapy. And I think that's what, was surprising to us. Though, one of the things we did see is that while we saw about a 20% response rate in patients with stable disease. Other patients progressed. They did include patients typically that we wouldn't treat with immunotherapy, like EGFR and ALK, though there were very few of those patients. The majority of these patients had mutations in the KRAS gene, which we'll probably hear more in some of the other sessions. But I think a very exciting trial, and we're hoping to see whether TILs do have a role. The TILs have been approved for melanoma, another solid tumor that had been known to respond to immunotherapy, and a certain percent of those patients progress after immunotherapy and are eligible for this TIL strategy. So it is something that is FDA approved for another cancer, and we're hoping to see more data with TILs in non-small cell lung cancer as well. So it's still early days, but there was some exciting presentations at ASCO. This was a poster using what is kind of a more novel way of using CAR Ts. One of the concerns with CAR T in solid tumors is it's been a long struggle to actually get them to be safe in patients with different solid tumors. And one of the struggles we, as oncologists and in the research and development field have struggled with is finding the right antigen or thing to go after. Because one of the things we've seen with CARs is that unlike drugs where when we do clinical trials, we're able to very tightly control how much drug we're giving at a very low dose and inch it up through phase 1 trials. With CARs, while we can change the dose of the CARs, it's a living drug. And so these drugs can expand quite rapidly and sometimes unpredictably in the blood. And so one of the ways to potentially make this more safe is this trial, this Everest 2 trial, looked at trying to look for something called loss of MHC or HLA-A02. This is a type of HLA that's seen in about 30% of patients in the US. And what they found is that this can be lost in cancer cells and generally is always present in normal cells. The reason cancer cells lose this is it can actually be one of the mechanisms by which immunotherapy stop working. So this strategy was clever because what they were able to do is use a CAR construct that works only when HLA is lost, which is something that we can test for using biomarkers. And then it targeted something called mesothelin, which has been tested in various CAR trials. But one of the concerns is toxicity to the lung. And as we know, we do worry as oncologists any of our therapies that cause lung toxicity because that can be, quite morbid and devastating for patients. And so that was the design of this, novel CAR construct. And, the idea here is that in the case of normal cells, which have HLA-A02, and again, this should be present in all normal cells, the CAR wouldn't be activated. But when the CAR sees a cell that had mesothelin and is lacking the HLA, which again is something that tumor cells can lose and something we can test for, the CAR can then kill it. And so, the way they set up this trial is, with a screening to confirm loss of the HLA. That's the major biomarker that they looked for. That allowed for patients to have their blood drawn, or this leukapheresis, which is where these T cells can get isolated. They then get engineered, and then the patient can then get administered the treatment, this mesothelin TMOD CAR. Again, most patients with CAR treatments are getting what we call lymphodepletion therapy, which is a short round of chemo to kind of prepare the body for CARs. There are very few patients that were studied. This is, again, still very early phase trial. I'm hoping we hear more about this soon. But this was an interesting example that they had in their poster of a patient with non-small cell lung cancer that actually, did have somewhat of a response to some of the lesions in the lung. And so, again, it's still early days and they're still working on getting the doses up and evaluating the safety. But, they did fortunately say that the side effects were fairly manageable and we didn't see any of the side effects that we typically worry about, like the pneumonitis that had been a barrier to targeting things like mesothelin, which is quite prevalent in non-small cell lung cancer. So very exciting data. This was another strategy that came out of a group in China looking at an antigen called CEA, which is present on a high percent of lung cancer. And interestingly, it's something that we can test for, in the blood. It's something that we typically don't routinely test for here, but it's not that uncommon that lung cancer can raise this antigen called CEA that we can detect in either the serum or we can stain the cancer cells for. And this CAR targets that protein which is present on the cancer cells. One of the strategies that they use to make this potentially a little bit safer is because CEA is expressed in some normal places in the body, is to make the CAR respond to what we call hypoxia. And so hypoxia is a fancy word for saying areas of the body that don't have a lot of oxygen. And one of the things we've learned a lot over the past few decades is that cancers actually tend to have very low levels of oxygen. And so I think this is an interesting and novel strategy to improve the safety by basically having the CARs work where oxygen is low, which then can improve the safety of this CAR while hopefully maintaining efficacy. And they tested some various doses of this in patients. And again, a lot of these patients had received multiple lines of therapy, including immunotherapies. And so very similar to the other trial, the CARs were collected and engineered, and then patients got chemotherapy in various doses and were followed up. And so they were seeing, some fairly impressive response rates and disease control rates of 47% for response rates, though, short-lived. I think the duration of response was only 2 months. But, I think, again, this is a promising approach because, while we weren't seeing, significant durability with this CAR construct, we did fortunately see safety. And, they measured various lesions of the body and were able to see responses in those or stability of disease. And again, a lot of these patients had, had prior immunotherapy. A lot of what we look at is CAR persistence. And, I like to think of CAR persistence as similar to how, we measure levels of, mostly in the context of a clinical trial, but we can measure the concentration of a drug in the body. And we, want to see if the drug is present when we're giving a dose of drug. CAR Ts can be measured, though not, in the same way as a drug, but actually measured in a different way and tracked over time. And what they were able to see is that the CARs actually persisted for quite some time, even after patients had progressed, interestingly enough. So we do see, a maximal amount of CARs in the bloodstream about 10 days after. But again, this really prolonged response or persistence was, very impressive for what we had expected with other CARs. And, there seemed to be a trend for the patients that had better responses with higher levels of that DA antigen. So lastly, we'll touch on small cell. We heard a lot from Dr. Cooper about a lot of the excitement, especially with tarlatamab targeting DLL3. This was a poster presented at ASCO, which looked at CAR T targeting that same protein DLL3, which again is present on the majority of non-small cell or small cell lung cancer, as well as some of the other types of neuroendocrine tumors. And, they tested various doses of the CAR therapy. And this, again, is a DLL3 targeting CAR, which had some further engineering to basically improve the persistence and the ability for the CAR to work in what we think is a, fairly, in this case, these patients had all received chemo and immunotherapy. So again, this patients that have already had resistance to immunotherapy. And what we're able to see is that we do see some responses, in these cases, some patients had stable disease and progression, but encouraging data. And, while they include, most of the patients had small cell, interestingly, they had broadened this to large cell neuroendocrine, which is in the similar family of small cell, it's a different type of rare cancer, that we do see, and that doesn't have tons of therapies approved. So very exciting that this could potentially play a role. And so we're seeing an impressive disease control rate of about 66%. And so, this is ongoing, and we have patients that are continuing on therapy. But, I think this is an evolving landscape as well. We have tarlatamab, as Dr. Cooper had mentioned, and, we're seeing excitement with that. So there's still an outstanding question, what's the advantage to the CAR T therapy compared to tarlatamab? And, one thing that I often discuss with patients is that with CAR T therapies, while it's an upfront, a lot more work in terms of visits and needing to get the chemotherapy and the infusion and often a hospitalization, these patients, after they get treated, aren't getting, treatment like every 2 weeks, like we would with other treatments, or every 3 weeks with some of our treatments. And so that's one of the paradigm shifts for us, is that while it's a lot more work for a patient up front, potentially, if this does work, patients would then just be monitored with scans, blood work, and getting their symptoms checked. And again, this was fairly well tolerated, similar to what we see with tarlatamab. With any of these therapies, we can see, things like cytokine release syndrome, which I often tell patients is, similar to like a bad flu or infection, that, we as oncologists have gotten much better at managing and recognizing the symptoms, as well as neurotoxicity, which can present with confusion and other neurologic changes, which again, I think we've gotten much better at recognizing and managing these compared to the earlier days when these therapies were starting to be used. So, I really think that CAR T and immune effector therapies are going to be very exciting for the future. I think these are going to play an increasing role for our lung cancer patients, and we're going to continue to see more and more trials in this space. There are barriers that we do need to overcome that I touched on, such as which antigen to go after, how we really prime the tumor microenvironment. Again, a lot of these patients had already had immune therapies, and the cancer had stopped responding to the immunotherapy. So how do we really address what we think is a hostile tumor microenvironment that's preventing things like T cells from working? And we also touch on persistence, the idea that we want the CARs around for a long time to be able to continue to fight any leftover amount of cancer there. So I think this is an exciting future, and we'd be interested to see as we get more trials for our patients.